So I'm going to be talking about the management of PV from a clinician perspective and how we take care of patients who have this entity on a day-to-day basis. I also like history of medicine, so I had to introduce a little bit of what I like relative to PV. A lot of my patients don't understand what it means to actually have elevated hematocrit and how you can distinguish that from other clinical conditions. So I think sometimes a picture is worth 1,000 words. So here's your normal blood and a mixture of hematocrit and plasma. This is when patients are anemic, where you have less blood or red cells, if you will, but this is what happens in polycythemia. So it's a true increase in red cell mass, right? And you have a lot less in terms of plasma. And I also like etymology, so I'm sure most of you know what polycythemia vera means. So it's the true increase in red cells, not the false or the secondary, if you will. And so most of the patients will present with elevated red cell count, ultimately with symptoms, and ultimately manifest with splenomegaly and propensity for clots and or bleeding. You know about the JAK2 and how it was discovered in 2005, but I don't know how many of you know that 4 groups discovered the exact same mutation in that exact same year, which is always very mind-boggling to me, but nevertheless, we know it's real and it exists. So I also know that many people, patients mostly, have difficulty. Why can't I advance this? Okay, let's see if this works. Yeah, I'm trying it, but whatever. Let's try something else here. Here, right? Yeah. Oh, here we go. There was a question about the JAK-STAT signaling, and in general, you have that little purple item that binds to the receptor, and it gets the JAK2 to dimerize and transmit the signal to the nucleus so that now all the blood elements start to get made. But when you have the mutation, A, you don't need that cytokine altogether, and B, the mutation causes the JAK to completely be close to one another so that signal transduction goes on all the time unopposed. And this particular activated enzyme does not get shut off, which is what typically happens under normal circumstances. It's the same. Maybe it's the video that's causing problems. So when we're evaluating patients in the clinic, I think of it as a triad of symptoms of splenomegaly, and propensity for bleeding or clotting. And then I'm always very mindful of progression to potentially advanced myeloid disorders such as myelofibrosis and leukemia. Fortunately, these are very uncommon events in people who have PV. You've heard a lot about symptoms that patients present with, fatigue being the most common of which. And I'll tell you that in my experience, I find that people who get diagnosed early on, some may be totally asymptomatic and they may be discovered by simple routine blood work, right? But as the disease progresses, then they will definitely start to develop symptoms that we will pay attention to. And Ruben and many others have put a lot of work into helping us evaluate the symptoms of patients who have MPNs in general, and I try very hard to capture those symptoms in my patients. You've also heard about risk-adapted management of PV, so we try to go by assessing the risk and whether your patient needs aspirin phlebotomy or whether they need cytoreduction. And generally in frontline, we're thinking hydrea and or interferon. But what's most important is that you need to think about evaluating the patient after a certain amount of time to say, is it time to move on to a different agent? And I think that piece is always missing somehow when people get evaluated or when they get referred to me, is that they are placed on hydrea and see ya in 6 months, you know? So without paying attention to many of the disease intricacies or perhaps response assessment, as should be the case. So as I was thinking about phlebotomy, I'm thinking, did we really need to wait 3,000 years before we said that, okay, maybe it's time to do something else? And it was so interesting to see that this was something that was utilized or done by the Egyptian that long ago. As I think it was Ruben who talked about how it was utilized for everything. And the root of it actually came from Hippocrates, who thought that everything was humors, and that if you were ill, it meant that one of the humors was not, in alignment with the other. And because Galen said, okay, blood is the most dominant humor, then people decided, well, maybe phlebotomy is the way to cure all. And then by the 18th century, everybody was using phlebotomy for bloodletting, for everything. In fact, they even discovered that leeches could do the same. Now, thankfully, we don't do leeches anymore. But more rational people, Virchow, Pasteur, and Koch, ultimately looked at the data, the scientific evidence, and said, wait a second here, maybe you don't need to use phlebotomy for everything, but nevertheless, it is still utilized in certain disorders, hemochromatosis being one, PV the other, porphyria cutanea tarda is the other entity. But what is the premise of phlebotomy? Now, we always say, yes, we're going to do phlebotomy in our patient, and we talk about the hematocrit, right? But the actual premise, and many patients don't grasp that actually, maybe you guys do, but I've seen some that don't. And the idea is to turn the patient iron deficient. That's because iron exists in the heme molecule. The heme molecule sits inside the hemoglobin, and it's actually responsible for transporting the oxygen to the tissues, right? That's one of the beautiful properties of the iron molecule. So when you're actually phlebotomizing the patient, you're taking out a ton of iron from the system, and you're going by the hematocrit to make sure that this is the level that you are, and that's basically decided or determined by clinical trials, which I'll share with you. So the point is to make the patient iron deficient so that the bone marrow doesn't have enough iron to make excess hemoglobin. So where did that 45% cutoff come from? It came from the CytoPV study, where investigators asked, well, at what level hematocrit are patients less likely to develop clots? Because if you looked at the books in the 60s, presumably patients who had PV, their life expectancy was about 18 months. And most of those patients died from thrombotic events, right? So it was an incredibly important question, and observational studies suggested that less than 45% for men, less than 42% for women, for hematocrit was, what we should aim for. But this was the very first prospective randomized study that kind of gave us the answer. And basically it was shown in the black line, it was the low hematocrit group, below 45%, compared with the patients who were kept at the high hematocrit group, that the risk of developing a major clot, PE or et cetera, like a lung clot or a clot in the leg, et cetera, was 4 times less likely to happen if you happen to be randomized to the low hematocrit group. So I think from that point on, it became sort of clear that this is where your patient needs to be. And then there was some interesting data with pegylated interferon in that, obviously after the discovery of the JAK2 mutation, that said, look, it's not just about phlebotomy and the hematocrit, that perhaps maybe we should go after molecular remission, and here's a drug that could cut down on the JAK allele burden. And in fact, some patients who may enter what we call molecular remission could discontinue this drug altogether and may not actually relapse, and that would be the point or the reason why you should be monitoring their JAK allele burden. Now, I've done this in clinical practice, but it's not, by no means a trial, but you could actually see a subset of patients that will result in reduction in allele burden. We need more studies to mean what that means prospectively. Ropeginterferon you heard about from various speakers, and it's a monopegylated version of the interferon that has just been approved. And unlike the study that the MPN Research Consortium did, which compared Hydrea and Pegasus outcomes at 1 year. This one looked at 1 year and then followed the patients up to 3 years. And if you look at the numbers, so Hydrea is in red, and then the Ropeginterferon responses are in bolded black. You'll see that the responses at 36 months looked so much better. So interferons in general tend to exert their effect, perhaps not the immediate effect, but long-term effect. They tend to exert the response slower. And so the conclusion is that the responses to Ropeginterferon continue to increase over time compared to Hydrea at 3-year mark. So I think that was a very strong conclusion, and that, I think, is what distinguished this study from the MPN Research Consortium study that looked at or evaluated Hydrea and Pegasus. Nevertheless, finally, we have an agent that was approved for hydroxyurea frontline when we actually did not have such an agent before. This is an injection that can be given every 2 weeks, and if the patient responded, I suppose you could transition to every 4 weeks as per recommendation, essentially. So I told you about the Hydrea, I told you about the Pegasus, and obviously we as physicians need to define patients who fail the first-line treatment, and that would be something that we need to kind of educate practitioners as to how to do and how to monitor the patients. If people continue to require phlebotomy, well, obviously your patient isn't responding as well to their treatment. And there's actually some literature out there suggesting that if your patient required more than 3 phlebotomies in a year, that perhaps their outcome may be slightly worse than those who don't. But nevertheless, those are criteria that have been developed by the European Leukemia Network to say this is what constitutes a response or doesn't constitute a response to your first-line treatment. And in all honesty, they were developed to identify a group of patients that may actually qualify to be enrolled on clinical trials. But I don't think it's unreasonable to use that in clinical practice to say, my patient is not responding well to the first-line treatment I'm using, and maybe it is time to move on to course B or what have you. So it's not just the phlebotomy, but it's also inability to control blood counts, inability to reduce spleen size, and or intolerability. If the patient is developing low blood counts or a toxicity from Hydrea, that would be the time to change. Okay, and then there's also ruxolitinib. You've heard about this, and it's another drug that's approved for patients who have not responded adequately to Hydrea. And the initial studies from the response trial demonstrated that you can have 60% of the patients that would be phlebotomy-free. A subset will also result in a reduction in their spleen volume, which is nice. So now I'm going to talk to you a little bit about a paper that's about to be published. She just got accepted this morning. And what we tried to do in this PV data consortium, and actually many of the physicians that presented today are investigators in this group, is that we wanted to gather data on patients who have PV that have been diagnosed in the last, since 2019, in the last 10 years, put it this way. And we wanted to address many of the questions that come, to answer areas of need that we don't know by looking and interrogating this database. So in this particular analysis, we wanted to see, is attaining or being able to have or attain an ELN response by the response criteria consistent or results in diminishing the likelihood of prognosis, and is it associated with disease progression to MF, for example, or death? And so, just to reiterate, the ELN response criteria is being able to have white count below 10, hematocrit below 45%, freedom from phlebotomy, and absence of splenomegaly. And of the 527 patients that we had in that PV data set, about 400 patients were receiving cytoreduction. So it's kind of nice to see what is done in the academic medical centers in patients who have PV. So you'll say, well, what about all the other patients that weren't accounted for? Well, probably they were only receiving phlebotomy. But those are the patients that were receiving cytoreduction, and most of those people received hydroxyurea, right? And this is the initial cytoreduction. Some had Pegasus, some had ruxolitinib, and very small percentage had interferon. But you'll see that at any time, those treatments shifted a little bit. So now more people later on in the study had ruxolitinib, more had pegylated interferon, telling you that there were people that did not necessarily benefit from their initial therapy. And not everybody responded, as you might have imagined. Pretty much 37% did not. But what was interesting in the final analysis, and this was very similar to the very first study that came out of this large data set, is that having not only leukocytosis, but also achieving not being able to achieve the ALN response criteria was not associated with any increased risk of thrombosis, but it was associated with increased risk of progression. So I think that is giving us all pause, and the major conclusion of this is that probably we should be looking at a prospective trial looking specifically at leukocyte control in this patient population. Maybe this is what's going to define to us a subset of patients that isn't responding to the treatments that we are offering them at this point. Of course, you can say, well, this is a retrospective analysis and you don't have it, and I agree with that. This is basically the limitation of the study. So now we can move on and talk about novel agents in PV. And I showed you that little picture of the red cell with the little heme and the iron in there to say that that's going to be a very exciting time to exploit our understanding and some of the novel agents in the management of PV along those lines. And perhaps it'll enhance our understanding as to what it means to control the iron metabolism, the ferritin, and all those parameters in this patient population. So, hepcidin, just before we go on to something called hepcidin mimetic, I'll just take a minute to explain to you what hepcidin is. So hepcidin is a protein that's produced by the liver, and it's the major controller of iron, not metabolism, but entry into the body, if you will. It controls a protein called ferroportin, and ferroportin sits on the surface is basically the door through which the iron gets into the cell or out of the cell, right? So it sits on the inside of the lining of the intestine, for example, or in the macrophages, which also hold down to some iron. So, and hepcidin controls that. So if you have low hepcidin, you can imagine there's a ton of iron that gets into the body, right? If you have inflammation, as would be the case in infection, and because iron is such an important molecule, when you have an infection, you want to limit the exposure, the availability of iron to bacteria, so you want to limit as much iron. You have so much hepcidin, and you stop the availability of iron so that you can control the infection. At least your body thinks it's controlling the infection. So it makes sense that you would use hepcidin mimetics to kind of control the iron and limit its availability. So now, instead of using phlebotomy, you are limiting the iron availability, and then your bone marrow is not able to produce extra or excess hemoglobin. So there are probably more than the two agents that I'm about to talk to you about, but one was already alluded to, rusfertide, which is a synthetic hepcidin mimetic that had already been explored in clinical trial. One of them was presented by Dr. Hoffman at past year's ASH. And in that clinical trial, it's a phase 2 study, they took patients that had a phlebotomy requirement. They had to have, of course, they had to have PV, and phlebotomy more than 3 in 6 months. And whatever treatment they had, they just simply continued on that, and they added this rusfertide as an add-on therapy. And as they sort of randomized them to nothing versus the drug, and then they followed them to see what happened to their phlebotomy requirement. And sure enough, it looked like they didn't, I would say 80% of those patients did not require any phlebotomy moving forward. So that's a very interesting methodology to say, okay, here's this agent that's going to act as hepcidin and is going to block the entry or the availability of iron to do so. But this was a phase 2, and hence I think we need to have a phase 3, as you know, to verify those phase 2 initial data. And this is basically the study, I'm trying to go back, the study that is ongoing right now, and it will be randomizing 250 patients to the ongoing therapy plus rusfertide or placebo. Everybody then will channel into an open label study, drug, and then an extension 20-week period to see if indeed this drug will result in reducing phlebotomy requirement, okay, for this patient population, and of course, looking at reduction in total symptom score. What about other methodologies or other approaches? So there's one other compound that is trying to utilize the body's own hepcidin. Now, rusfertide is a synthetic analog of hepcidin. In this situation, this novel agent, what happens is that it controls the production of hepcidin. I'll show you how. But here, if you somehow increase the body's production of hepcidin, then essentially you attain the same result, right? You also limit the availability of iron to the bone marrow so that you don't have enough blood production, enough iron for excess blood production, essentially. So how is that accomplished? Well, this drug inhibits something called TMPRSS6, and TMPRSS6 inhibits hepcidin. I know it gets complicated, but if TMPRSS inhibits hepcidin, so if you block this, then now hepcidin generation gets increased. So essentially, you're allowing the patient's own hepcidin to increase, therefore mimicking what you would like to see and result in, again, a reduction of the hemoglobin generation and hopefully reducing the frequency of phlebotomy. And that is the study objective and endpoint, which you would expect that in patient population that is requiring of phlebotomy. They're also looking at total symptom score to see if what type of impact on quality of life those new agents might have. So that takes me to my last slide. So you can see that maybe phlebotomy continues to be an important aspect of taking care of patients like this who have PV, but that we need to pay attention to active therapy, evaluate patients when we are treating them actively, consider alternate treatments, consider clinical trials that look at novel agents. In fact, that's how we managed to get novel agents approved for this entity. And I'm very much looking forward to understanding the role of hepcidin mimetics in the treatment of this entity.